Welcome to PRISM Rounds, the audio journal club where we break down one study at a time for ICU, ED, and pulmonary/critical care teams, physicians, trainees, nurses, pharmacists, and respiratory therapists. A quick note before we start, this episode is created using AI-generated voices. I originally made these episodes to support my own learning and review, and I'm sharing them publicly in case they're helpful to other busy clinicians and learners. Because the voices are synthetic, you may occasionally hear mispronunciations of medical terms, drug names, or author names. Thanks in advance for your patience. Everything you'll hear is for education only and not medical advice. Let's get into today's paper.
I want you to start by just imagining something for a second. Imagine there's an invisible alarm bell installed somewhere really deep inside your chest.
Oh, wow. That sounds incredibly stressful already.
Right. And it's loud.
Mm-hmm.
It's this jarring, blaring thing, and it demands your absolute physical attention.
You literally can't ignore it.
Exactly. You can't ignore it. Now imagine this alarm goes off, say, 30 times an hour. Every single hour. Every day.
That's practically every 2 minutes.
Yeah. You can't unplug it. You can't, silence it. You can't even muffle the sound. For years, this is just your baseline reality.
It's just a constant, inescapable state of emergency.
Right. 30 times an hour, your body just goes into this violent spasm of warning.
Mm-hmm.
And that is the daily, grinding, completely exhausting reality for patients living with a specific lung disease who suffer from a chronic cough.
It really is a genuinely harrowing way to live. I mean, when we think of a cough, we usually conceptualize it as, a temporary annoyance.
Cold or something.
Yeah, exactly. Like a post-viral tickle or maybe some environmental dust. We rarely think of it as a permanent, life-altering neurological and physical burden.
But for the patients we're talking about today, it's not temporary at all.
No, not at all. For the patients in the trial we are analyzing today, the cough isn't a symptom of something passing. It is a permanent fixture of their existence.
It just wrecks everything, right?
It does. It fragments their sleep, it completely shatters their social lives, and it just physiologically drains them.
So welcome to the deep dive. Today we are opening up a really remarkable piece of medical research.
It's a fascinating study.
We're looking at the CORAL randomized clinical trial. This was published in JAMA in 2026.
Right, led by Dr. Philip Molyneux and this really massive international consortium.
Yeah. And our mission today is to basically unpack the methodology, the really complex receptor science, and the key findings of this study.
Which is testing an experimental drug, right?
Exactly. A drug called Nalbuphine extended release, or Nalbuphine ER. They want to see if it can finally provide some actual relief for patients with idiopathic pulmonary fibrosis-associated cough.
Which is such an important mission because this specific area of respiratory medicine has just been a therapeutic desert for decades.
A complete desert.
Yeah. The patients dealing with this specific type of cough have been, honestly, entirely left behind by both standard pulmonology and standard palliative care.
Which is why this trial is so utterly fascinating. Even if you, the listener, are perfectly healthy right now, this deep dive is a total masterclass in how modern clinical science navigates, seemingly unsolvable problems.
It really is. We're going to look at how researchers can actually quantify a subjective reflex.
Using advanced digital acoustics, right?
Yes, and the complex biostatistics required to handle missing data in clinical trials, plus how this kind of paradoxical pharmacological mechanism might just hijack the brain-lung axis to, turn off that internal alarm bell.
So to start, before we can really appreciate the elegance of this drug, we kind of need to understand the brutal architecture of the problem itself.
Right. We have to look at the disease.
Yeah. We're dealing with idiopathic pulmonary fibrosis, or IPF. We know it's a progressive fibrosing interstitial lung disease.
Meaning it causes scarring in the lungs.
Exactly. The delicate, spongy tissue of the alveoli, where the actual gas exchange happens, it turns into this thick, rigid scar tissue.
The pathophysiology here is just devastating. I mean, you have to picture the cellular environment of the lung.
Okay, paint a picture for us.
Normally, the interstitial space, so the scaffolding that supports the air sacs, is incredibly thin. It allows oxygen to diffuse effortlessly right into the blood.
But in IPF, that changes.
Radically. For reasons that still entirely elude us, which is why it's called idiopathic, the fibroblasts, the cells responsible for wound healing, they basically go rogue.
They just start working overtime for no reason.
Yeah, they start continuously depositing collagen and extracellular matrix into that really delicate scaffolding.
So it's like this unchecked runaway wound healing process where there isn't actually a wound to heal.
Precisely. And because of that, the lungs become this stiff, sort of honeycomb-like structure. They lose all their compliance.
I mean, they can't stretch out.
Right. They can't stretch and recoil easily. So patients have to generate massive negative pressure just to pull a normal breath in.
It sounds exhausting.
It is. And it is a terminal diagnosis. The median survival rate is only 3 to 5 years after diagnosis.
Wow. 3 to 5 years.
Yeah. The sheer mechanical failure of the organ leads to progressive respiratory failure.
And layered on top of that really grim prognosis is this cough. The data shows up to 80% of IPF patients suffer from this chronic cough.
80%. That's a massive proportion.
And looking at the baseline characteristics of the patients in the CORAL trial, it's honestly heartbreaking.
Yeah.
We are talking about a median age of 71, mostly men.
Right.
And the duration of their cough averaged between 3 to over 5 years. Some of them had literally been coughing for a decade.
A decade of constant coughing. The sheer metabolic output of coughing that much is just staggering.
It takes so much energy.
It really does. You're expending vital energy that a failing respiratory system simply doesn't have to spare. I mean, a cough is a violent maneuver.
It's not just a little tickle.
No, it requires rapid, forceful contraction of the diaphragm and the intercostal muscles against a closed glottis, and then there's an explosive release.
And doing that 30 times an hour.
You are constantly interrupting your oxygen intake. These patients experience severe hypoxia. They suffer from rib fractures just from the mechanical stress of the cough.
Wait, they actually break their own ribs from coughing?
Yes. Rib fractures, stress incontinence, and deep, deep psychological trauma.
I can't even imagine. The social isolation has to be pretty much total.
Oh, absolutely.
Going to a restaurant, sitting in a movie theater, or even just trying to hold a normal conversation with your family, it becomes a source of deep anxiety.
You are essentially a prisoner to your own vagus nerve.
So what does standard medicine do for this? The standard of care for IPF focuses entirely on the fibrosis itself, right?
Yes. We do have antifibrotic drugs now, things like nintedanib or pirfenidone.
Right.
They intervene in the biochemical pathways of those rogue fibroblasts we mentioned earlier to try and slow down the collagen deposition.
But the key word there is fibroblasts. They don't do anything for the cough.
Nothing at all.
I kind of think of it like putting heavy steel braces on the outside of a crumbling building.
That's a good analogy.
The structural integrity is failing, right?
Yeah.
And the braces, the drugs like nintedanib, they might keep the building standing a little bit longer. They slow down the collapse.
But they don't fix the core issue.
Exactly. And those braces do absolutely nothing to stop the fire alarms from blaring 24/7 on the inside.
Right.
For the people actually trapped in that building, the blaring alarm is what's ruining their day-to-day existence.
And in the phase 3 trials for those antifibrotics, the symptomatic burden, the cough, remained completely untouched. The decline in lung capacity was slowed, sure, but the patients were still coughing just as much.
So the obvious question is, why not just give them typical cough medicine?
Right. Why not just treat the symptom directly?
Yeah, I mean, if someone has a chronic cough, doctors usually just throw the kitchen sink at it, right? Proton pump inhibitors for silent reflux, inhaled corticosteroids for inflammation, gabapentin.
Or even just over-the-counter stuff like dextromethorphan.
Right. Why did those all fail?
Because the mechanism of the IPF cough is fundamentally different from, say, asthma or reflux or a lingering post-viral cough.
How so?
Well, a normal defensive cough reflex is triggered when chemical or mechanical nociceptors, those are the nerve endings in your airway, detect an external irritant.
Like smoke or inhaling a piece of food.
Exactly. They detect the irritant, and they send a signal up the vagus nerve to the medulla oblongata in the brainstem, and then the brainstem fires back the motor command to cough.
But in IPF, there is no external irritant to expel. There's no smoke or crumb.
Right. The irritant is the physical distortion of the lung architecture itself.
The scar tissue.
Yes. The massive deposits of scar tissue are physically stretching and warping the airways. So this constant pathological tension continuously fires the mechanical stretch receptors.
It's literally just the shape of the lung causing the reflex.
Exactly. Furthermore, the fibrotic environment is highly inflammatory. It's bathing the local C fibers and A delta nerve fibers in these sensitizing cytokines.
So the nerves are extra sensitive on top of being stretched.
Yes. The threshold for triggering a cough drops to almost 0.
Wow. So the hardware is physically bent out of shape,
Yep.
and the software is like completely hypersensitized.
That is exactly the issue. Traditional cough suppressants might soothe a mildly inflamed mucosal lining, from a cold.
Right.
But they are entirely powerless against the severe structural distortion and the profound neurochemical sensitization happening in a fibrotic lung.
You can't just turn off mechanical stretch receptors with an inhaled steroid when the entire organ is essentially turning to stone.
You really can't.
So we are at a therapeutic dead end. The standard lung drugs don't stop the cough, and the standard cough drugs don't work on the lungs.
Which forces a total paradigm shift.
Right. If you can't fix the sensor inside the burning building, you have to bypass it entirely.
You have to go straight into the neurological control room.
The brainstem and the central pathways. You literally have to rewire the alarm panel. And that brings us to the experimental drug in the CORAL trial, Nalbuphine extended release.
Yes. Nalbuphine ER. It operates on the cough reflex arc, both centrally, meaning in the brain, and peripherally, down in the nerves of the lungs themselves.
And it's an opioid, right?
It is an opioid, but to understand why it's so unique, we have to look very closely at the receptor science.
Because opioids and coughs, they have a long, really complicated history.
Oh, absolutely.
I mean, for over a century, traditional opioids were the gold standard for cough suppression. Bayer famously marketed heroin as a cough medicine back in the late 1800s.
Which sounds wild to us now, but yes.
And we still use codeine syrups today.
We do, because opioids are incredibly effective at dampening the central cough centers in the medulla.
Right.
They bind to opioid receptors, which broadly inhibit the release of excitatory neurotransmitters. But the opioid receptor system isn't just a single on-off switch.
It's more complicated than that.
Much more. It's a complex family of receptors. You primarily have the mu, kappa, and delta receptors.
Okay, mu, kappa, and delta.
Right. Traditional opioids, things like morphine, oxycodone, codeine, they are strong mu-opioid receptor agonists.
Meaning they activate the mu receptor.
Exactly. They act as the chemical key to turn the mu receptor on.
And turning that mu receptor on gives you profound analgesia, right? The pain relief.
Yes, very strong pain relief.
But it also gives you the euphoria, the severe physical dependence, the extreme constipation.
All the classic side effects. And most critically, for this specific discussion, mu receptor activation causes respiratory depression.
It slows down your breathing.
Yes.
Wow.
It directly inhibits the pre-Butzinger complex in the brainstem, which is essentially the rhythm generator for breathing. It tells the body to breathe slower and shallower.
Okay, wait. Giving a mu-opioid agonist to a 71-year-old patient with end-stage pulmonary fibrosis,
Right.
a patient whose lungs are already failing, and who is already struggling with hypoxia, I mean, that sounds like medical malpractice.
It is highly, highly dangerous.
You are suppressing the basic drive to breathe in someone who is literally starving for air.
Exactly. That is why pulmonologists are incredibly hesitant to use morphine or codeine for these patients outside of strict end-of-life palliative care. The risk of fatal respiratory depression is simply too high.
So how does Nalbuphine ER navigate this minefield? Like, if it's an opioid, how is it safe for a terminal lung patient?
Because Nalbuphine ER is a mixed agonist-antagonist.
Okay, break that down for us.
Specifically, it is a mu-opioid receptor antagonist. So instead of acting as the key to turn the mu receptor on, it acts like a broken key jammed in the lock.
Oh, I see.
It occupies the mu receptor without activating it. And by doing that, it physically blocks other endogenous or exogenous opioids from binding.
So it actively shields the mu receptor.
Yes.
It completely blocks the pathway that causes the euphoria, the addiction, and most importantly, the fatal respiratory depression.
Exactly. It takes the mu receptor out of the equation entirely.
But wait, if it's blocking the mu receptor, it still needs a mechanism to actually suppress the cough, right?
It does, and that comes from its action on a totally different receptor. Nalbuphine ER is a potent kappa opioid receptor agonist.
Ah, so it blocks mu, but it activates kappa.
Yes, it actively turns on the kappa receptors.
The kappa receptor seems to be like the unsung hero of the nervous system here.
It really is a fascinating receptor. Kappa receptors are densely distributed in both the central nervous system and the peripheral atrial nerves down in the lungs. When activated, they inhibit the release of neurotransmitters like substance P. And substance P is crucial for transmitting the cough signal from the lung to the brain.
So by agonizing the kappa receptor, Nalbuphine acts as a highly specific volume knob.
That's a great way to put it.
It just turns down the sensitivity of the overactive vagus nerve signaling. It calms the cough reflex while completely bypassing the mu receptor's dangerous suppression of the respiratory drive.
Yes,
The pharmacological elegance of that is just stunning.
it is.
It's a targeted strike on the specific neural pathway driving the symptom while actively barricading the pathways that would, harm the patient. On paper, it's the perfect drug.
It is. But as any pharmacologist will tell you, the graveyard of clinical development is just packed with drugs that look perfect on paper.
Right. Animal models don't always translate.
Exactly. The leap from in vitro receptor binding affinity in a lab to a living, breathing, coughing human being with complex fibrotic lung disease is massive.
You have to actually prove that this dual action mechanism translates into measurable clinical relief.
Which is incredibly hard to do.
And that brings us to the choral trial methodology. How do you actually prove this works?
Right. Let's look at the trial design.
Dr. Molyneux and his team designed a Phase 2b, double-blind, parallel group, placebo-controlled trial.
The gold standard.
Yeah. And they ran this across 52 different clinical sites in 10 countries. They screened over 200 patients and ultimately randomized 165 of them.
The scale of that is really impressive for an orphan disease indication. I mean, Phase 2b is really the critical inflection point in drug development.
How so? What makes 2b different?
Well, Phase 1 proves the drug isn't overtly toxic. Phase 2a shows some early signals of efficacy, but Phase 2b is the dose-finding mission.
You're trying to find the sweet spot.
Exactly. You have strong biological plausibility, but you need to know the exact therapeutic window before you commit hundreds of millions of dollars to a massive pivotal Phase 3 trial.
Right. So to find that window, they divided the 165 patients evenly into 4 groups.
4 separate arms.
One group received a placebo, just a sugar pill. And the active drug groups received varying doses of Nalbuphine ER, 27 milligrams, 54 milligrams, and 108 milligrams, all taken twice a day.
But the dosing strategy wasn't just to hand them a bottle of pills and send them home.
No.
They implemented a highly controlled 2-week blinded dose titration period.
So they didn't just start them on the max dose right away.
Right. Patients assigned to the higher doses didn't start at 108 milligrams on day 1. They started at a lower dose and systematically stepped up over 14 days.
And then that was followed by a 4-week fixed dose period where they stayed at whatever their target dose was.
Exactly.
We will definitely get into the biological necessity of that titration period when we talk about the side effects later, because it is basically the only reason this drug is tolerable.
It's a huge factor.
But right now, I want to talk about how they measured the outcome, because measuring a cough objectively seems incredibly difficult.
It historically has been a nightmare.
I mean, if you just ask a patient, hey, how much did you cough today? Human memory is notoriously terrible.
We are so bad at it. We adapt to chronic stimuli. We forget.
Yeah. Relying on patient diaries for primary endpoints in cough trials has basically been a disaster in the past, right?
It introduces massive placebo effects and subjective recall bias. If you want a hard, objective primary endpoint, you have to completely remove the human element.
So how do they do that here?
The CORAL trial used a specific piece of technology called the VitelloJAK monitor to measure the absolute change in 24-hour cough frequency.
So patients just wore this digital monitor for a full 24 hours at baseline, and then again at week 2, week 4, and week 6.
Right. And this isn't just a basic microphone recording audio like a dictaphone. It's a dual sensor system.
Oh, really? How does it work?
They wear a piezoelectric chest sensor adhered directly to the sternum to measure physical vibrations, and that is paired with an ambient microphone attached to their lapel.
That's intense. But why both?
Because the engineering behind acoustic respiratory monitoring has to be highly sophisticated. A pathological cough has a very distinct physiological profile.
Right.
There is a deep inspiratory gasp, then the closure of the glottis to build intrathoracic pressure, and then there's the explosive expiratory phase where the glottis opens and air is expelled at high velocity.
Okay.
The VitelloJAK system captures both the acoustic frequency of that explosion from the mic and the physical vibratory recoil of the chest wall from the sternum sensor.
But if I'm wearing this array for 24 hours and it's picking up every sound I make, how does the trial differentiate a genuine IPF cough from, say, me just clearing my throat after lunch?
Or laughing?
Yeah, or laughing at a television show, or even just a really loud car driving by on the street.
That is the exact challenge of digital signal processing in these clinical trials. I mean, the initial raw data, 24 hours of audio and vibration for 165 patients over multiple weeks, is absolutely massive.
Terabytes of audio.
Exactly. So the Vitalogy uses specialized algorithms to filter the audio first. It looks for the specific amplitude, frequency, and explosive signature of a cough event, and it corroborates that with the vibratory data from the chest sensor.
Ah, I see. So if it's just a loud car, the microphone peaks, but the chest sensor doesn't vibrate.
Precisely. And if it's a throat clear, the acoustic envelope is entirely different from the explosive pressure release of a true cough.
So it uses AI to compress those 24 hours down to only the relevant acoustic events.
Yes. But it doesn't stop at the algorithm?
No.
No, and this is crucial for the integrity of the trial. The algorithm compresses the data, but human beings verify it.
Oh, wow.
The compressed audio files were uploaded to a secure portal for central reading by highly trained acoustic technicians.
Having a central reading room is so vital. I mean, if you leave the interpretation up to the individual doctors at the 52 different local clinical sites.
You introduce massive inter-rater variability.
Yeah, exactly. Some doctors might be more lenient, some might be stricter on what counts as a cough.
Central reading standardizes the entire data set. The technicians in the reading room are completely blinded.
So they have no idea what drug the patient is on.
They have no idea if the file they're listening to is from a patient in the placebo group or the 108 milligram high-dose group. They are just meticulously counting validated cough events based on strict acoustic criteria.
And when they established a baseline, using this incredibly rigorous system, the numbers were just staggering.
They really were.
Before any patient took a single pill, the baseline average across the groups was between 24 and 31 coughs per hour.
A violent pathological cough roughly every 2 minutes.
And that spans the entire 24-hour cycle, including when they're trying to sleep.
Right. The objective baseline roots the entire trial in undeniable reality. We aren't just guessing at the severity anymore. We have machine-measured, human-verified data proving the profound mechanical dysfunction.
So, okay, the trial is set. The patients have gone through their 2 weeks of blinded titration, and they've been on their fixed dose for 4 weeks, 6 weeks of treatment in total.
Yeah.
They strapped the Vitalogy monitors back on. What did the data actually reveal?
Well, the primary findings were robust and highly statistically significant. Let's look at the objective reduction in cough frequency at week 6.
Okay, lay it on us.
The placebo group, so the patients taking the inactive pill, saw their cough frequency drop from 29.4 coughs an hour to 28.1.
That is a 16.9% reduction.
Right, which is a classic demonstration of the placebo effect, or perhaps regression to the mean.
Yeah, the simple act of participating in a highly monitored clinical trial, having doctors pay close attention to you, it can actually modulate symptom perception and even slate physiological responses.
Exactly. It's an expected baseline drift,
Yeah.
but the active drug groups tell a completely different story.
What happened there?
In the lowest dose group, the 27 milligrams, the average drop was 47.9%.
Okay.
For the 54 milligram group, it was 53.4%. And for the highest dose, the 108 milligrams, the reduction was a striking 60.2%.
Wow. Let's actually ground those percentages in absolute numbers, particularly for that 108 milligram group. They went from an average of 31.5 coughs per hour down to 11.9.
That is a massive difference.
Think about that practically. It's going from a cough every 2 minutes to a cough every 5 or 6 minutes.
Right.
Now, obviously, it doesn't cure the underlying disease. You are still dealing with severe fibrosis.
Unfortunately, yes.
But dropping to 11 coughs an hour gives the patient windows of peace. They might actually be able to get through an entire meal without a severe coughing fit. They might achieve a complete cycle of REM sleep.
The physiological relief of cutting the cough burden by 60% just cannot be overstated. The energy preservation alone is a massive benefit for someone with end-stage lung disease.
There's a specific statistical detail regarding the primary analysis that really caught my eye here, though.
Oh, the outlier.
Yes. It involves how they handle a massive anomaly in the data, and I think it speaks to the really rigorous honesty of the researchers.
You're referring to the outlier in the placebo group.
Ex-
In clinical trials, human biology is messy, right? And you sometimes capture bizarre physiological events.
So what happened?
At week 6, one single patient in the placebo group had an astronomically high spike in their objective cough count. It was an extreme outlier compared to the rest of the cohort.
It could have been an acute exacerbation of their IPF, maybe? Or maybe they just caught a completely unrelated viral bronchitis during week 6?
Whatever the cause was, that single patient's massive data spike heavily skewed the average of the entire placebo group.
So it made the placebo group look worse than it actually was.
Yes. If the researchers had kept that outlier in the primary analysis, the placebo group's average end-of-trial cough count would have looked significantly higher.
And consequently, the relative performance of the Nalbuphine ER groups would have looked far more miraculous by comparison.
Exactly. It would have artificially inflated the drug's apparent effectiveness.
But they didn't do that.
No. The researchers conducted a post-hoc sensitivity analysis that actually excluded that extreme outlier.
Wow. By doing so, they actively chose to hold their experimental drug to a much tougher, more conservative standard.
They really did. They cleaned up the placebo group's data to make it as competitive as possible.
And even against that conservative baseline, the higher doses of Nalbuphine ER still achieved p-values of less than 0.001.
Meaning the statistical significance was rock solid.
Right. And the other hallmark of a rock-solid pharmacological effect is the dose-response relationship, which is clearly visible here.
Very clearly. 27 milligrams yields roughly 48%, 54 milligrams yields 53%, and 108 milligrams yields 60%.
It's like a perfect staircase.
That escalating staircase is exactly what you want to see in a Phase 2b trial.
Because it proves it's the drug doing it.
It confirms that the biological mechanism is directly tied to the concentration of the drug. As you increase the occupation of the kappa-opioid receptors, the suppression of the cough reflex arc deepens proportionally.
It strongly suggests the result is not just statistical noise, but a genuine pharmacological effect.
Absolutely.
Okay, so the VitaloJAK machine, the algorithms, and the blinded central readers all agree. The drug objectively works. It silences the alarm.
It does.
But this raises an incredibly complex issue in clinical medicine, the difference between objective biomarkers and subjective reality.
Right.
A machine proving a 50% reduction in coughs is fantastic for an FDA application. But if the patient themselves is still utterly miserable, what have we actually accomplished?
This is the eternal struggle in treating chronic symptoms. You have to capture the patient-reported outcomes to validate the objective data.
How did they do that in the CORAL trial?
They utilize several highly validated secondary endpoints. They use the Exactly Respiratory Symptoms IPF cough subscale.
Okay, so that asks the patient to rate the frequency of their cough.
Yes, and they use the cough severity numeric rating scale, the CSNRS, and most importantly, they use the Leicester Cough Questionnaire, the LCQ.
The Leicester Cough Questionnaire is fascinating because it doesn't just ask for a number.
No, it goes much deeper.
It measures health-related quality of life across physical, psychological, and social domains. It asks if the coughing causes stomach pain, if it interferes with work, if it makes the patient feel depressed or embarrassed.
It attempts to quantify the holistic human toll of the disease.
And this is where the data reveals a really profound nuance. We established that all the active doses, even the lowest 27 milligram dose, significantly reduce the objective cough count measured by the machine.
Right. The 27 milligram group saw nearly a 48% drop.
But when you look at the patient-reported questionnaires, the 27 milligram dose completely failed to reach statistical significance compared to the placebo.
It's a striking disconnect.
The machine said they were coughing half as much, but the patients themselves didn't feel any better in terms of frequency, severity, or overall quality of life.
It wasn't until you look at the 54 milligram and 108 milligram doses that you see statistically significant, robust improvements across those subjective questionnaires.
Only the higher doses align the objective reality with the subjective experience. Let's really analyze that disconnect because it feels like a psychological paradox. Why wouldn't a patient notice that they're coughing 48% less?
It seems counterintuitive.
I try to conceptualize it as a threshold of annoyance. If someone is poking you with a sharp stick 30 times an hour and they suddenly reduce it to poking you 15 times an hour, you don't thank them.
Right.
You are still angry, you are still in pain, and your day is still completely ruined by being poked with a stick. You don't actually perceive relief until the poking drops below a certain threshold where you can ignore it.
That is a highly accurate conceptualization of chronic symptom burden. The neurobiology of chronic irritation is deeply tied to neuroplasticity and central sensitization.
So the brain changes.
Yes. When a patient has suffered from a relentless, severe stimulus for years, their entire nervous system rewires itself around that trauma. The brain enters a state of hypervigilance.
The brain is constantly waiting for the next cough.
Exactly. Even if you reduce the objective frequency by 48%, going from 30 coughs to 15 coughs an hour, still means the patient is experiencing a violently disruptive, exhausting event every 4 minutes.
Every 4 minutes is still awful.
Their sleep architecture is still shattered. Their social anxiety is still triggered because they are still coughing during dinner.
Right.
The baseline hypervigilance remains intact because the disruptive events are still frequent enough to completely dominate their attention.
So the subjective burden remains massive, even as the objective count drops.
Yeah.
You haven't broken the cycle of sensitization.
But at the higher doses, dropping down to roughly 11 coughs an hour, paired with the potential central nervous system soothing effects of the higher kappa agonist concentration,
Right.
the patients seemingly crossed that vital therapeutic threshold. The intervals between the coughs finally became long enough for the nervous system to begin downregulating its hypervigilance.
The patients actively felt the relief.
Yes, and their Leicester Cough Questionnaire scores showed a significant and very meaningful bump in their holistic quality of life.
And when you look at the responder analysis, you see how transformative those higher doses were for specific individuals.
The responder analysis is key.
They didn't just analyze the group averages. They looked at the proportion of patients who achieved a massive, specific milestone of relief.
Right. They looked at the percentage of patients who achieved a 75% or greater reduction in their objective cough counts.
A 75% reduction.
In the 108 milligram group, an astonishing 43.2% of patients hit that mark.
Nearly half the patients on the highest dose saw their coughing slash by 3/4.
Exactly. Compare that to the placebo group, where only 5.6% of patients achieved a 75% reduction organically.
Wow.
If you're a patient in that responder category on the 108 milligram dose, the drug isn't just taking the edge off. It is fundamentally rewriting your daily reality.
It is returning a degree of autonomy and peace that the fibrosis had completely stolen from you.
It really is.
Which sounds completely miraculous. But in pharmacology, every action has an equal and opposite reaction.
There is no free lunch in pharmacology.
We have to talk about the catch. You cannot start heavily agonizing and antagonizing central opioid receptors without causing some systemic collateral damage.
Absolutely not.
What is the biological cost of this neurological relief?
Oh, the safety profile is heavily dominated by gastrointestinal and vestibular adverse events.
Like nausea and dizziness.
Yes. And this is entirely expected given the mechanism of action. The human gut is densely packed with opioid receptors, which modulate motility.
Right.
And the brainstem houses the area postrema, which is the chemoreceptor trigger zone that induces vomiting. And that zone is highly sensitive to opioids.
So when we look at the adverse events tables, the incidence rates were incredibly high, particularly in the mid and high dose groups.
Very high.
In the 54 milligram group, 50% of the patients experienced nausea. Half of them. And across the active drug groups, up to 35% experienced dizziness, nearly 28% experienced vomiting, and another 28% experienced severe constipation.
There were also significant reports of fatigue and somnolence.
Looking at those numbers in a vacuum,
Yeah.
you might assume the drug is practically intolerable.
It certainly looks that way on paper.
I mean, if half your patients are nauseous and a third are actively vomiting and dizzy, that sounds like a failed clinical trial. If a doctor tells me a pill has a 30% chance of making me vomit and a 50% chance of constant nausea, I might honestly prefer to just keep the cough.
The cure sounds as bad as the disease, right?
Exactly.
But this is where the trial data presents a massive, fascinating paradox. Despite these staggering numbers for nausea and vomiting, the discontinuation rates were virtually identical between the active drug groups and the placebo group.
Wait, that makes absolutely no sense.
It's true.
How can half the active cohort experience severe gastrointestinal distress, yet they drop out of the study at the exact same rate as the people taking a sugar pill? It was like around 5% for both. Right.
To resolve that paradox, we have to look at the severity grading of the adverse events and, crucially, the specific timeline of when they occurred.
Okay, so tell me about the severity first.
The vast majority of these events were classified as grade 1, which means they were mild and didn't require medical intervention.
So they weren't hospitalized for vomiting?
Right. Furthermore, there were 0 fatal adverse events related to the study drug. But the real key to understanding this is the timeline.
When did all this happen?
Almost all of the nausea, vomiting, and dizziness happened right at the very beginning of the trial, during the 2-week blinded titration phase.
The period where they were slowly stepping up the dose.
Exactly. When you first introduce a potent kappa agonist to the central nervous system and the gut lining, the body is shocked.
It doesn't know what to do.
Right. The chemoreceptor trigger zone fires, the vestibular system is thrown completely off balance, and gut motility alters. The body panics.
Right.
But the human nervous system is incredibly adaptable. Downregulation and tolerance to these specific side effects happen rapidly.
How rapidly?
The median duration for the nausea across the trial was only 6 days. The median duration for the vomiting was a mere 2 days.
Ah, it's the pharmacological equivalent of getting your sea legs.
That's a perfect way to describe it.
If you've never been on a boat in open water, the first day is miserable. The horizon is moving, your vestibular system is deeply confused, and you might spend hours hanging over the rail.
It's an awful experience.
It is. But if you just ride it out, your brain recalibrates.
Yeah.
Your inner ear adapts to the motion. You get your sea legs, the nausea entirely fades, and you can finally walk around and enjoy the cruise.
That is precisely the biological mechanism at play here. The patients got their pharmacological sea legs.
And this highlights the absolute genius of the 2-week blinded titration period in the trial design.
It was a stroke of brilliance.
By starting the patients on a low dose and slowly ramping it up over 14 days, the researchers allowed the body to adapt to the vestibular and GI shock incrementally.
Right, because if they had just handed the patients the maximum 108 milligram dose on day 1,
the acute shock to the area post-strima would have been overwhelming.
the dropout rate would have skyrocketed and the trial would have likely failed purely due to intolerability.
Wow. The slow ramp-up managed the adaptation process perfectly. By the time the patients reached the highly effective 108 milligram fixed dose at week 3, their bodies had mostly built a tolerance to the side effects.
The nausea had passed.
And they could finally experience the profound relief from the chronic cough without the distraction of extreme gastrointestinal distress.
It really proves that tolerance to the adverse effects builds incredibly quickly.
But, and this is a big but, that brings us to the crucial limitations of this study and the vast unknowns moving forward.
Right. We can't declare a victory just yet.
The drug is tolerable if titrated correctly. It significantly reduces the objective cough count. It improves subjective quality of life. But a phase 2b trial is just a stepping stone.
It is entirely preliminary. Science demands rigorous, long-term replication.
And the most glaring limitation of the CORAL trial is the duration. The treatment phase was only 6 weeks long.
Which is very short.
6 weeks is a blink of an eye for a disease that patients endure for years. It tells us practically nothing about the long-term viability of the drug.
And that short duration raises an alarming question about receptor pharmacology. We just discussed how rapidly the body builds a tolerance to the side effects of the kappa agonist, right? The gut and the vestibular system adapted in mere days.
So the obvious fear is, does the body also build a tolerance to the primary therapeutic benefit?
Exactly.
If the nervous system is downregulating receptors to stop the nausea, won't it eventually downregulate the kappa receptors in the cough reflex arc too?
It's a very real concern.
If a patient takes this drug for 6 months or 2 years, will the 60% reduction hold steady, or will the cough slowly come roaring back?
That is the great unknown, and it is a fundamental challenge with all chronic opioid therapies. Receptor downregulation, tachyphylaxis, and diminished efficacy over time are very real phenomena.
And if the efficacy wanes, you might have to continuously increase the dose.
Right, which could re-trigger the adverse events or cross a line into entirely new toxicities. A 6-week trial simply cannot answer that question.
That is why long-term open-label extension studies and massive phase 3 trials spanning 52 weeks or longer are absolutely critical here.
A phase 3 trial is an entirely different beast. You need hundreds, potentially thousands of patients across dozens of countries to prove safety and efficacy to the FDA beyond any shadow of a doubt.
And conducting a trial of that scale brings up the final, highly complex caveat of the CORAL study, the biostatistics.
Yes. The missing data.
Specifically, how the researchers handled missing data. In any clinical trial, especially one involving terminally ill patients, you will have missing data.
It's unavoidable. Patients miss appointments, the Vitalogic batteries die, or patients withdraw entirely due to disease progression or side effects.
And you can't just delete the patients who dropped out from the final analysis.
Yeah.
If you only look at the data from the people who successfully finished the 6 weeks, you introduce massive survivorship bias.
Exactly. You're only looking at the winners. To handle this, the researchers utilized a complex statistical model for their primary endpoint called the Mixed Model for Repeated Measures, or MMRM.
Let's really break down the MMRM, because understanding how researchers model missing human data is crucial to interpreting clinical science. How does it actually work?
Well, the MMRM is a longitudinal data analysis technique. It doesn't just throw out the patient who dropped out at week 4.
Okay, so what does it do with them?
Instead, it looks at the data that patient did provide at baseline and week 2. It analyzes their specific trajectory. Then, it looks at the trajectory of all the other patients in that exact same dose group. Using complex covariance matrices, the model mathematically estimates or imputes what that missing patient's data likely would have been at week 6 had they stayed in the trial.
Oh, wow. So it's an algorithmic prediction based on the behavior of the herd.
Yes, but, and this is a massive but in biostatistics, the entire MMRM framework rests on a fundamental assumption, the missing at random assumption.
What does missing at random actually mean in this context?
It means the statistical model assumes that the reason the patient dropped out is entirely unrelated to the drug's effectiveness.
Okay.
It assumes that a patient who withdrew at week 4 would have continued to follow the same basic trajectory of improvement as the patients who stayed until week 6.
Well, what if they aren't missing at random? What if a patient in the 108 milligram group dropped out at week 4 specifically because the drug suddenly stopped working for them and their cough came back worse than ever?
If that happens, the data is missing not at random. And if the data is missing not at random, the MMRM's mathematical prediction is fundamentally flawed.
The model will assume the patient continued to improve when in reality they were getting worse.
Exactly. This can result in the model painting an overly optimistic picture of the drug's overall success.
Now, to their credit, the paper is highly transparent about this limitation. They explicitly acknowledge that while the MMRM is standard practice for FDA trials, the underlying assumptions carry inherent risks of bias.
They do.
But even weighing the short duration, the side effect profile, and the statistical caveats of the MMRM, you look at the raw absolute numbers. You look at the responder analysis showing over 40% of patients achieving a 75% reduction.
Right.
It is incredibly hard not to be profoundly optimistic for these patients.
The optimism is highly warranted. The effect sizes demonstrated here, particularly the dose-response relationship culminating at the 108 milligram dose, represent a massive leap forward.
It really does.
For a severe disease state that has endured decades of failed symptom management trials, Nalbuphine ER represents the first genuinely targeted, mechanistically sound beacon of hope.
Let's pull the lens back and summarize the journey we've been on today. We started in the devastating cellular environment of a fibrotic lung.
Right, where unchecked scar tissue physically stretches the airways, acting as a permanent, immovable trigger for a relentless cough.
We explored how standard antifibrotics and traditional cough medicines fail entirely against this mechanical and neurochemical distortion.
And then we broke down the pharmacological elegance of Nalbuphine ER.
A drug that navigates the complex opioid receptor network. It jams the mu-opioid receptor to actively prevent fatal respiratory depression while agonizing the kappa-opioid receptor to dial down the vagus nerve's hyperactive signaling.
And through highly rigorous methodology utilizing advanced digital acoustics, central blinded reading rooms, and careful titration schedules, the trial proved that the higher dosages not only slashed the objective cough frequency by over 60%,
but they successfully crossed the neuroplastic threshold required for patients to genuinely feel their qualities of life improve, all while managing a predictable wave of initial side effects.
It's a truly remarkable study.
To you, the listener, thank you for diving into the deep end of this medical research with us. It is very easy to scroll past a headline that simply says, "New drug helps lung cough." But it is infinitely more rewarding to understand the intricate receptor biology, the complex statistical modeling, and the profound human struggle hidden beneath those headlines.
We hope you walk away with a deep appreciation for the ingenuity required to push clinical science forward.
The ability to intercept and rewrite a biological signal when the underlying organ is failing is truly a marvel of modern pharmacology.
It is.
Before we wrap up, I want to leave you with a final provocative thought to mull over. Today, we analyzed how a drug successfully rewired the reflex arc of a severely damaged lung, achieving profound symptom relief without suppressing the basic drive to breathe. If we can achieve this level of targeted, safe neurological modulation, what does this mean for our broader understanding of the brain-body connection?
It opens up an entirely new frontier in palliative and chronic care.
If we can isolate and quiet the distress signals of a dying lung, could we eventually map and turn off other agonizing reflexive symptoms of terminal illnesses directly at the neurological source? Could we learn to bypass damaged organs entirely and grant peace to the brain itself? Think about that invisible alarm bell going off in your chest 30 times an hour. We might not have the technology to put out the fire in the building yet, but for the first time, we might finally understand how to cut the wire to the alarm.
Thank you for spending your time with PRISM Rounds. If this episode helped you think through the paper or offered something practical for the bedside, I'd be grateful if you'd like, follow/subscribe, and share it with a colleague. It's the simplest way to help this resource reach other busy clinicians and learners. I'm also trying to make the podcast better with every episode. Please leave a comment with what you found most useful, what felt unclear or too long, and what topics or papers you'd like covered next. If there's anything I can do to improve, pacing, structure, level of detail, or audio quality, I genuinely welcome the feedback. Thanks again for listening, and take care. Educational use only. This is not medical advice.